This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Pineal Cyst Surgery Beyond Morphology, a critical evaluation of a consecutive surgical series.
This is a topic that hits home for anyone who spends time in a neurosurgery clinic. We see these patients all the time, young, often female, presenting with an incidental or perhaps not so incidental finding on an MRI. The management of pineal cysts, or PCs, has always been a bit of a gray zone in our field, hasn't it?
Absolutely. The prevalence of these cysts in the general population can be as high as 37.5%, depending on the MRI study you look at. Most are asymptomatic and stay stable, but when a patient presents with a 1.5 centimeter cyst and a chronic headache, the controversy begins. This study from the Hanover Medical School team really tries to move us away from just looking at the size, the morphology, and focuses on clinical radiological correlations.
I like the beyond morphology angle. For years, people just argued over whether 10 millimeters or 15 millimeters was the cutoff for surgery. But we've both seen patients with small cysts who are miserable and patients with huge cysts who are fine. What was the cohort size in this paper?
They looked at 46 symptomatic patients treated between 2008 and 2024. It's a consecutive single-center series. Out of those 46, 18 underwent surgery and 28 were managed non-surgically. What's interesting is how they decided who got surgery. It wasn't just a random choice. They used 4 specific criteria: PC growth, symptom-oriented indications, suspicion of a tumor based on things like nodular enhancement or wall thickening, and of course the presence of hydrocephalus.
And what were the symptoms? I assume headache was the big one.
You guessed it. Headache was the most common symptom in both groups, at 80%. In the surgical group, the next most common were visual disturbances, at 33%. In the non-surgical group, they saw vertigo in about 32% of cases. They also noted nausea, vomiting, sleep disorders, and even endocrinopathy.
That's the challenge. Those symptoms are so nonspecific. If you operate on every patient with a headache and a pineal cyst, you're going to have a lot of unhappy patients when the headache doesn't go away. This is where their radiological analysis becomes critical. Did they find any smoking guns on the scans that predicted who actually needed surgery?
They actually found some very specific metrics. First, let's talk about the aqueduct. The surgical patients had significantly narrower aqueducts compared to the non-surgical cohort. We're talking 0.9 millimeters versus 1.6 millimeters. That's a statistically significant difference with a p-value of less than 0.001.
That is a huge takeaway. It suggests that even without overt hydrocephalus, meaning the ventricles aren't necessarily blown out, there might be a functional crowding or a subclinical narrowing of the aqueduct that contributes to the symptoms.
Exactly. And they also looked at predominant expansion. They defined this as the direction of maximal radial displacement from the center of the pineal recess. They found that anterior expansion, where the cyst pushes toward the third ventricle and the aqueduct, was present in 67